Good afternoon. Thank you, Chairman Grasso and council members. Thank you very much for holding this roundtable. My name is Kirsten Hawkins, and I'm a pediatrician practicing in the district since 2003. I have practiced in a variety of settings to include a local pediatric emergency room, in 2 different high school-based health centers, and in 2 different academic primary care practices. I'm a district resident, and I have 2 daughters, both of whom are in the district schools. I'm here today representing the board of directors of the district's chapter of the American Academy of Pediatrics. The district's chapter strongly encourages the council to consider legislation establishing a 40-hour minimum safety net, as you called it, of nurse presence in the DC public and charter schools. The district's chapter is a supporter of the broader community and school health integration efforts that the Department of Health is proposing in the context of the whole school, whole community, whole child model. However, we are unable to identify any evidence to support reduction in school nurse hours. The American Academy of Pediatrics released a policy statement in June of this year emphasizing the importance of school nurses in child health. The first recommendation is that pediatricians advocate for 1 full-time professional school nurse in every school, and DC public schools should not be exempt from this recommendation. I would argue that children in DC are at an increased risk when compared nationally. As reported by the Academy of Pediatrics, nationally 1 in 10 children have asthma. However, in DC, child lifetime asthma prevalence is 19% overall. The Department of Health has stated that it will keep nursing levels where they are if the needs assessments dictate. I would urge the council to question what would justify any school in DC having less than a full-time nurse. In its June 2016 report on its system-wide needs assessment, the Department of Health concluded only 1 piece of evidence to support cutting nurse hours. These graphs that showed that many children in DC who should have individual health plans do not have them, regardless of whether or not their schools have full-time nurses. Well, given that the nurses are required for completing these plans, solution would be to improve efforts to complete them rather than to reduce the effort that is placed. Earlier this month, the Department of Health asserted that we have local strong assets and one of the highest insurance coverage rates in the country. While yes, we do have strong insurance rates, however, coverage rates do not actually translate to strong utilization. Just this past month, I took care of an insured child who attends a DC public school. The child immigrated to the U.S. last year. She's woefully behind on her vaccines. She's in need of 13 vaccines to catch her up to date. And yet she's been in school for more than a year without any identification of having a need for this. How was she even enrolled without a student health certificate in the first place? At any given school, less than 50% of enrolled students have a completed up-to-date health certificate on file with the school nurse. And while I do many of them every day, they just don't get necessarily to where they need to be. When a nurse does have a form, he or she must manually input that data into a database and then scan immunization forms to the registry. And that's a step up this year. Previously, they had to fax. How can we include the acuity of student health needs in an algorithm to determine nurse coverage if we don't even know what the needs are of the students in those schools? And furthermore, the health suite utilization is another factor in the proposed algorithm. However, on days when there is no school nurse present, in my own children's school as well, there's no documentation of health suite utilization because there's no one there to enter that data. Of further concern is the Department of Health's assurance regarding medical emergencies. Department of Health has asserted that non-medical staff members are trained to administer medications, provide basic first aid, and activate EMS services when nurses are not in place. In my own child's school, there are currently 2 trained staff members to administer medications when the nurse is not in place. Neither of these staff members are trained in providing first aid or have basic CPR certification. Just yesterday, there was no school nurse present, as she's now covering a different school on Mondays, and 1 staff member was attending the training to become a certified medication administrator, and the remaining certified staff member was out ill. So in the 3rd largest elementary school in the city, there was no one trained to provide medications yesterday in the school. There's over 30 or 40 students with chronic health conditions in this school with asthma, sickle cell disease, epilepsy, life-threatening allergies. This is not what I would expect for the standard of care for my children, let alone anyone else's child. A teacher or a school administrator is not a health professional who can assess and respond to a child's status at the level a trained nurse can do. The district's ongoing problems with emergency response times make the prospect of a child's seizure, asthma attack, diabetic emergency, choking, or an anaphylactic reaction happening in the absence of a school nurse all the more concerning. Enacting a 40-hour minimum for nurse coverage in DC schools would establish an important foundation for comprehensive efforts to improve child health throughout the schools. As a physician, as well as a parent, I appreciate the council's attention to the health and safety of DC children and hope that we can extend what's due to them.
Thank you very much. Good afternoon. It's a big day.